All right, everyone. I think we're going to go ahead and get started. I want to thank you so much for joining us today. This is our Research Connection hosted by the American Foundation for Suicide Prevention, North Dakota chapter. We are thrilled that you are here to join us for our first virtual Research Connection. Some housekeeping things before we get started. Please be sure to mute your microphones. The schedule of the day is going to work. We're going to have an hour of our presentation, and then we will have 30 minutes at the end for Q&A. So please, just so that we all can hear the presentation well, please be sure to mute. I will be watching the chat box, and as well as if you have a question, you can unmute at the end of our presentation. Just a little bit about the American Foundation for Suicide Prevention. We are a national organization and we're built up of a series of chapters. So it's kind of the best of both worlds. We have the power and expertise of a national organization, but we're doing things locally on the local level. AFSP is active in a number of different ways. On the national level, we're known for our mental health research. On our local level, we're known for prevention education, advocacy, and support for loss survivors. It's our mission at AFSP to save lives and bring hope to those affected by suicide. I want to thank everyone who has supported the Out of the Darkness walks across the state of North Dakota. Thanks to the support of these events, we can bring this program and many other programs to North Dakota at absolutely no cost. So if you've walked with us before, thank you so much for your support. I should also note this is being recorded and you will be able to find this on our website after the presentation is over. AFSP is very proud of our research. As some of you might know, we are the #1 private funder of mental health research. And that is why we are so excited to have this virtual research connection here in North Dakota. I am going to introduce our researcher, Dr. Kelly Cukrowicz, Professor of Psychological Health, School of Veterinary Medicine, Texas Tech University. She received her PhD in clinical psychology from Florida State University in 2005, and then completed internship and a postdoctoral fellowship at Duke University Medical Center. She joined the faculty of Texas Tech University as assistant professor in 2006 and was promoted to full professor in 2017. She received a Young Investigator, Pilot, and Standard Grant from the American Foundation for Suicide Prevention. She received the Edwin Scheinman Early Career Research Award from the American Association of Zoology in 2014. She has been honored with the Bernie E. Rushing Jr. Faculty Distinguished Research Award, the College of Arts and Science Excellence in Research Award, and the Nancy J. Bell Excellence in Mentoring Award from Texas Tech University. Her research has examined the role of relationships on the onset and maintenance of thoughts of suicide in middle-aged and older adults. She has conducted studies aimed at examining the prevalence of thoughts of suicide and history of suicide attempts among adults in rural communities, as well as at how risk factors required to rural life contribute to risk. Much of this research includes variables that are part of journals Interpersonal-Psychological Theory of Suicide and the Model of Risk, reformulated by von Orden. Now we're going to start our research connection.
All right, shall I go ahead and start? Okay. Am I muted?
Nope, we can hear you loud and clear.
Okay. All right, cool. On my Zoom spot, it said ask to unmute, so just wanted to double check. Okay, well, I'm going to talk mostly today about suicide risk in rural communities and talk a bit about some of the work that I've done over the course of my career. I'll just start with some basic information about suicide. And as I move forward to this slide with prevalence of suicide, I should have changed that number on there to 2019. Actually updated these slides, this slide this morning with the newer data. And one of the things that I was thrilled about in updating that number is that the number was smaller in 2019 than it was in 2018. And over the course of my career, it's been very unusual for the number to get smaller. It is the 10th ranking cause of death in the United States, and we see a much greater rate of death by suicide among men than we do women. This slide shows the numbers by race and gender, and we see that men, again, as I noted before, die by suicide at a higher rate than women, and that those numbers are especially noteworthy for American Indian, Alaska Native, and white non-Hispanic males. Here we see the methods of suicide that are most frequently used. This data illustrates that men who die by suicide more frequently choose firearms, followed by suffocation. And for women, women pretty equally die by firearm, poisoning, or suffocation. This slide depicts the difference across age. And what we see is that suicide deaths tend to be higher generally among male older adults. And this has been a strong focus of my work in trying to understand that. One of the things we have seen is a greater shift in the number, again, especially noteworthy among men, but we're starting to see it among women as well in that 45 to 54-year-old kind of middle-aged section of the life bracket. When we look at risk factors across the lifespan, they do differ some among older adults versus, for example, adolescents and children. But I've included in this slide the risk factors that seem to be pretty common at different life stages. And these include a family history of suicide, family history of child maltreatment, previous suicide attempts, psychological disorders, particularly depression, alcohol and substance abuse, feelings of hopelessness, impulsive or aggressive tendencies, cultural and religious beliefs, particularly the belief that suicide is a noble resolution of a personal dilemma, local epidemics of suicide, isolation, particularly a feeling of being cut off from other people, barriers to accessing mental health treatment, loss, that can include relational loss, social, work, or financial, physical illness, easy access to lethal means, and an unwillingness to seek help because of the stigma attached to mental health and substance use disorders or suicidal thoughts. That's a lot. When we look at rural communities, we know that suicide is prevalent in rural dwelling adults in the US, and the research supports that in other countries of the world as well. Rural communities have had higher rates of suicide than urban areas throughout the last couple of decades, and particularly among older adults, that number is 30 to 50% more likely to die by suicide compared to those in urban locations. Conducting suicide in rural communities is very challenging. I will say when I first started working in some of the rural communities outside of my area in Texas, it took us a long time to actually get started beyond the point that we were really interested in expanding the work in rural communities. And some of the concerns that came up related to accessing services. In more populated areas, when you do a suicide risk assessment and someone indicates they're thinking of suicide, there's lots of resources available, but that doesn't tend to be the case in rural communities. And myself, I had a lot of hesitation about beginning work that might lead people to negative experiences after acknowledging suicide risk to us. In addition to those limitations in medical and mental health services, we also see differences in how people think about mental health in rural communities, and oftentimes more of a feeling that that's something that you talk about to your family, but you don't talk about that to other people, and there can be a lot of stigma. And so we had some concerns about whether we would get accurate reporting from folks in our rural communities. And then the last thing that I think is really noteworthy is concerns from folks about how we would respond when they reported thoughts of suicide to us. When people have the belief that if they say that they're thinking about suicide, that will necessarily lead to an inpatient hospitalization, they may be far less likely to acknowledge those thoughts and feelings, when I would hope that in most for most well-trained clinicians, that would be more of a last resort than a first resort. Unfortunately, that can be an idealistic view that I have, and oftentimes isn't actually the case. So when we look at what risk looks like in rural communities, there are some patterns that we see. One is with regard to gender, that there's a higher suicide rate among men. That, again, that holds regardless of rural communities. Veteran status, rural veteran risk was 20% greater than urban veterans in a study that looked at that. Lethal means, particularly access to pesticides and firearms. Economic stressors, a lack of reliance on others for assistance. So kind of that self-reliance value and the individualistic values that are sometimes more common in rural communities. Cultural values such as honor, self-sufficiency, stoicism. As I mentioned before, avoidance of sharing problems and stigma. Then also limited community infrastructure for suicide prevention, and geographic and social isolation. So I've gone over a really large number of risk factors, and it's really hard to organize that information and in a way that can be clinically useful. And so for much of my career, I've done work that is theory-based in trying to organize some of that information within a theory that provides a fewer number of sort of touchstone risk factors that we can look at that may account for some of those other risk factors that I included on those last couple slides. So the interpersonal theory of suicide is the theory that I've spent much of my career focused on. And the interpersonal theory, I'm going to assume many of you are familiar with it. Some of you may not be, so I will go ahead and go through it in a little bit of detail. The interpersonal theory suggests that people who feel a thwarted sense of belonging and a perception that they are a burden on other people and feel hopeless about those feelings changing are those that are most likely to desire suicide. So we talk about thwarted belongingness. We're talking about feelings of loneliness or that other people are not connected in a caring way within your relationships. Perceived burdensomeness, we think, is most likely among people that feel like they are a liability on other people, or they would be better off if that person weren't part of their life or wasn't around anymore. And then they feel a sense of resentment or hatred toward themselves for creating difficulty or liability on other people. The theory suggests that if you feel a sense of burdensomeness, or that you are that you're not connected to other people, but you don't feel both of those things, that you're more likely to have thoughts of death. So that would be thoughts like, it would be nice if I wouldn't wake up tomorrow morning, or that you wouldn't be sad if something happened to you. In contrast to that, the theory suggests that people who feel both a thwarted sense of belonging and that they are a burden on other people are the ones that are more likely to desire suicide. In the paper that I have referenced below, we also argued that it is important to consider how likely it is that those feelings are going to change, and that if they're transient thoughts, even together, they're less likely to lead to a desire for suicide than if a person really feels like that it's not going to improve, things aren't going to get better. So moving forward in the model, among those who desire suicide, the individuals most likely to have a lethal or near lethal suicide attempt are those that have acquired the capability for suicide. And the kind of two key components of that are a lowered fear of death and increased pain tolerance. So for someone who desires suicide and has also acquired the capability for suicide, those tend to be the folks that we're most concerned about. Thinking back to those risk factors that I mentioned before, oftentimes people who are feeling anxious, depressed, otherwise isolated, you can think of those as experiences that lead to perceptions of burdensomeness. In the paper that I have cited there, we kind of went through many of those common risk factors for suicide and talked about how those experiences may lead people to have a perception of burdensomeness or feel a thwarted sense of belonging. So in the interpersonal theory, suicide ideation is an important red flag. We tend to think of it as a critical flag for those who might die by suicide. However, it is important to keep in mind that most people who think about suicide don't die by suicide. However, if you never think about it, your risk is obviously, generally speaking, much lower. Not that there are not exceptions. But there's some important things to keep in mind. One of those is that many people who are at risk for suicide don't disclose their thoughts of suicide. Lots of people who think about suicide don't ever harm themselves, and suicide ideation can also be chronic. This figure depicts past year suicidal thoughts and behaviors among individuals in the US. And what we can see is that there's a lot more people who have serious thoughts of suicide compared to those who make a serious suicide attempt. That is generally great news. It does, however, create difficulty from a prevention perspective in cases where a person doesn't acknowledge suicide ideation, or for prevention approaches that target those generally considered at highest risk, such as attempters, groups who are more often to die on a first attempt. Older adults fall into that, or those who attempt with more lethal means, especially on an early attempt. So it really highlights the need for methods to identify individuals who may not tell us about their thoughts of suicide or their history of suicidal behavior. In other words, we don't want to wait until someone has attempted suicide before we move forward with prevention. So older adults are a really nice example, and for much of the sort of first half of my career, I focused almost exclusively on older adults. But with rural communities and older adults, we see a very similar pattern of not a whole lot of reporting of suicide risk, but then when you compare that to the rate of death by suicide, there's a contradiction there. So I'm going to start with the example of older adults. So research suggests that older adults may not report suicide ideation even when they experience it. And kind of how do we know that? Why do we think that? The first contradiction is that the rates of death by suicide increase in late life. At the same time, that rates of self-reported suicide ideation decrease within increasing age. So while across the lifespan death by suicide is going up, reported suicide ideation is going down. The second contradiction is that older males are more likely to die by suicide, but when we look at reported suicide ideation, there's no gender difference in males and females there, where you would think that with older males dying more frequently, we would see greater reporting of suicide ideation among men. So what do we do when things don't add up? So we have a person who denies thoughts of suicide, but their actions suggest otherwise, and they have some of those risk factors or warning signs that I mentioned in the previous slides. So this is an example. This is what one of our data sets look like. And so I'll start here and kind of talking about this issue of underreporting. So what we see with this distribution is at the far end, a lot of people who are reporting that they're not thinking about suicide. So the far end, on my slide, it's to the left, reflects the lowest possible score for suicide ideation or death ideation. And what we started to wonder with the contradictions I talked about previously is whether there may be sort of two types of people in that big stack of zeros, or people denying thoughts of suicide or thoughts of death. One set of those zeros is people who are not thinking about suicide. They genuinely are not. They're not obscuring. They're not avoiding talking about it. They're also not telling us anything about experiences of depression, feeling like a burden. Everything that we know about them suggests, in fact, that they're not thinking about suicide. But then we hypothesize that there might be another type of person that is in that zero, and that's a person that's not telling us that they're thinking about suicide, but everything else that we know about them suggests that maybe they are. So as we go forward, I'm going to use the language of potential ideator to refer to those people that are telling us that they're not thinking about suicide, but in fact, we have concerns that they might be. So my research group conducted a study with older adults. And so we had sort of two goals with this study. One was to figure out if the hypothesis of the interpersonal theory that the combination of thwarted belonging, perceived burdensomeness, and hopelessness would be most painful or associated with the greatest thoughts of death and suicide ideation when a person is reporting all three of those things. And then we also wanted to know, and I'll focus a bit more on whether elevated scores on those three experiences would allow us to identify people who deny thoughts of suicide, but again, we think that they might actually be experiencing thoughts of suicide based on the additional information we have about them, particularly things like depressive symptoms and isolation. So on these slides, the zero represents a zero probability of being a non-ideator, or on the flip side, 100% likelihood of being a potential ideator. And I'm talking about the zero on the y-axis. So again, the potential ideator is the person reporting zero suicide ideation, but their other responses look very similar to those who do report thoughts of suicide. And what we see on these two figures is that individuals with greater scores on thwarted belonging and perceived burdensomeness are near that zero line. So what that means is that we believe those are potential ideators. So people who are reporting no suicide ideation, but perhaps experiencing it. And we see a similar story on this slide. So as reported experiences of perceived burdensomeness, hopelessness, and thwarted belonging increase, the probability of a person being a non-ideator reduces substantially. It's basically zero, suggesting that that individual is very likely to be experiencing suicide ideation, even if it's not reported. Elevated scores on perceived burdensomeness, thwarted belonging, and hopelessness, again, are associated with a greater probability that they are experiencing suicide ideation. So what do we do with that information? So what that tells us is among communities or age groups or rural versus urban with a focus on rural, if you have concerns that someone might not be honest about thoughts of suicide, then we can think of these other experiences, perceived burdensomeness, thwarted belonging, and hopelessness, as determinants of whether someone might be experiencing thoughts of suicide, regardless of whether they're telling us that they are thinking about suicide. And particularly from the prior figures, we're talking more about higher scores than lower scores. So if someone reports a really low score on one of those things, that's not so much cause of concern, but particularly if they're reporting significant experiences with that, and again, it's kind of additive, if it's all three of them, then that certainly is much greater cause for concern. So given that, questions regarding thwarted belonging, perceived burdensomeness, and hopelessness, they may be less threatening to endorse or talk about than thoughts of suicide, which makes them a good starting place. And we believe that mental health practitioners should target perceptions of being a burden, a thwarted sense of belonging, and hopelessness to reduce the risk of even developing thoughts of suicide. So my team wanted to expand this work to middle-aged and older adults, particularly in rural communities. I have a real strong passion for rural communities. There tend to be fewer services, but no less need among these communities. And so when I started working in this area, as I mentioned before, I had a lot of concern about, can we do this in a way that is safe and comfortable for those that participate in the research? And will we see enough variability in reported thoughts of suicide to be able to identify what some of those specific risk factors are? So the preliminary goal or primary goal in the initial work that we've done has been to determine an estimate of the prevalence of suicide ideation, self-injury, and history of suicide attempts in the communities that we went into, and then to begin looking at risk factors that may be unique to rural locations. So in the initial study that I conducted, the data that you see here summarizes what was reported to us. And so we had questions about lifetime history of suicide ideation attempt, ideation in the past year, previous suicide attempts, and suicidal communications. And what you can see is that over 20% of the people that participated in our study reported a lifetime history, and more than 10%, 13 or so percent, reported suicide ideation in the past year. So while that's really concerning, at the same time, it's helpful to know that at least in the communities that we studied, in rural area in Texas at least, folks were comfortable with reporting these experiences. On the other side of the slide, you can see how our data compared to a cross-national study. Methods were a little different, but the questions that were asked were the same. And what you can see is that the percentage is much higher in our rural communities than it is in the cross-national data. So several years ago, AFSP funded basically everything I've presented so far, AFSP has funded, which has been a great blessing of my career. But after we did that preliminary study, we put forward another grant proposal that was ultimately funded to look at more specific risk factors for rural communities. And so this slide has a lot of things on it, but what we conceptualized was that there may be vulnerability factors such as illness, disease, economic strain, isolation that lead to emotional pain. And so that can include things like depression, anxiety, hopelessness, substance abuse, shame. And that for those that experience that emotional pain, that may be associated with or lead to feelings of thwarted belonging and perceived burdensomeness. Now, for some people, the elements of their life, other people, their perspective on things may serve to then protect them from having thoughts of suicide, where for other people, the elements of their life may place them at greater risk of having suicide ideation. And so those are the two bubbles that I included, the two circles for moderator variables. So on the plus side is things, protective factors, reasons for living, satisfaction with life, hope, positive affect, religiosity, and forgiveness. And then on the sort of negative side is limited access to help, a very strong sense of independence, stigma related to mental illness, and then a sense of pride that, yeah, I may feel this way, but I'll deal with it by myself. So among those that have kind of moved forward in our model in terms of having risk and went on to develop suicide ideation, then we've also looked in this model at some more specific factors related to rural communities that may increase acquired capability. And in terms of the lowered fear of death, that may be access and familiarity with guns and pesticides. In terms of pain tolerance, things like hunting, manual labor, daily experiences with pain may increase pain tolerance, and that together those two kind of community-specific ways of lowering fear of death and increasing pain tolerance may lead to greater acquired capability. So at the point of completion of the study and conducting some preliminary analyses, we kind of looked at how some of those elements of rural identity and economic distress were associated with some of those emotional pain and interpersonal theory variables. And what we found was that economic distress was really important to having people report greater sense of lack of belonging from other people, greater anxiety, depressive symptoms, and being a burden on other people. And then we saw a connection between burdensomeness, anxiety, and thwarted belonging with suicide ideation. And then among those who reported suicide ideation, many of those also reported a history of suicide attempts. And in looking at those kind of risk and protective factors in the moderators, those that were important in that transition between I hope you can see my cursor, but the variables in brown impacting the relation with suicide ideation were things like life satisfaction, hope, lower conformity to masculinity norms, and then reasons for living. So kind of taken together in summary, what we saw is that some of those variables that are associated with rural life, particularly economic distress, seem to be associated with perceptions of burdensomeness and disconnection from other people. Painful experiences with burdensomeness and disconnection were reported associated with greater reports of suicide ideation, but there's hope in that experiences of hope and life satisfaction. And some of those other resilience factors did seem to sort of buffer folks from experiencing or reporting thoughts of suicide. We also saw that pain and some of those related experiences may be associated with the ability to carry out a suicide attempt, though that part is preliminary. Even though we had a decent sample size, the number of people that reported a history of suicide attempts was still fairly small from a statistical perspective. So I want to transition and kind of move into more of a clinical direction. But before I do, I wanted to just touch on COVID-19 a little bit as it pertains to suicide risk. My hope had been when I prepared these slides, I could do a lit search and I'd find all kinds of research. I hear people talking about research with COVID-19 all the time. And I lead my university's institutional review board, which is the committee that approves research with human subjects or people. And we see studies all the time on COVID-19. And so I really thought that I'd find lots. I did not find lots, which tells me people are still doing this work and it's probably somewhere in the publication pipeline, but not out yet in terms of being able to have a lit search turn up lots of new data. However, I did find a really great article from the International Association for Suicide Research that kind of summarized what some of the concerns are, and I'll touch a little bit on them as we go forward. So they noted concerns with COVID leading to untreated mental health concerns. And there's really obvious ways that that's happening. People can't increasingly in some communities are now starting to be able to seek in-person mental health services. But in the beginning, it kind of took some time for people to transition from in-person services to using Zoom more comfortably. And so there was definitely a gap there in the beginning of our COVID pandemic of people just not getting the services that they had been receiving before in the midst of a very stressful time. I think we're doing better with that now. I think most mental health providers have transitioned to offering services by Zoom or by telephone. And so I think that has improved. Another area that is of concern is hospitalizations. Again, so it was undoubtedly worse in the beginning of the pandemic, but the hospitals were much more hesitant to have people in their hospital given concerns about exposure to COVID. In my area, I was doing some clinical work at our Health Sciences Center, and I know that the hospital was far less likely to make a decision that someone needed to be hospitalized right at the beginning of the pandemic unless the situation was very, very significant in terms of risk. And they also were doing COVID tests for everybody, which of course they needed to. But then there was occasional issues with someone test positive for COVID at the same time that they're having a mental health emergency. In some cases, that may be because of COVID. And in other cases, the mental health emergency was present before they had exposure to COVID. Among the other concerns are prolonged isolation and separation from supports. That has been particularly noteworthy for older adults in assisted living and nursing communities that have gone a long time without the regular visits that they were receiving before. Economic hardship and unemployment, illness and grief due to both COVID infection as well as people who are close to an individual who've died from COVID. Family distress due to lockdowns. Most families don't spend 24 hours a day together for months on end, and in some communities, that's been the reality of COVID. And then uncertainty and anxiety about the future. So I'm going to transition now into talking a little bit about assessment of suicide risk. So when we talk about assessment of suicide risk, one of the really key things I feel really, really strongly about is that we start by educating people about what we're going to ask and what we're going to do with that information. I think one of the leading causes of people avoiding disclosure of thoughts of suicide is concern that they will be hospitalized or that there will be some other very negative experience that follows that information. So I always start my suicide risk assessments with education about what I will do if someone reports thoughts of suicide. And I want to be specific. I'm certainly not going to obscure for folks that in some cases we do sometimes have to make decisions regarding hospitalization. But I want to be really clear that that doesn't happen very often when I'm the person assessing, and that I'm going to go through every alternative I can think of before we go to that point. I also encourage you to ask questions about perceived burdensomeness, thwarted belonging, and hopelessness. I hope you're convinced about why, given the information I presented already. Also think it's really important to normalize thoughts of suicide. So I've just given you a couple of quotes that I often use. One is, it sounds like you've been experiencing a lot of emotional pain recently. Others in your situation might think of suicide. Have you had any thoughts of suicide recently? And my goal there is to take it out of the realm of there's something wrong or unusual about you if you are thinking of suicide, and to say, gosh, anybody who's going through what you're going through might be thinking about suicide. If you are, let's talk about it. I might also ask, have you felt like people might be better off without you, or that you are a burden? Or have you felt isolated or disconnected from other people? I usually begin my assessments with the past and work forward. Obviously, this is going to depend on how much time I have. If it's a limited period of time, I don't have the luxury to do that. But if it's a longer time that I have with somebody, I'll ask them about the first time they remember thinking about suicide, just to get them comfortable with talking about those experiences, and then work forward. And in doing that, we have a hope or expectation, at least I do, that by the time we're talking about now, they've been talking about it enough minutes with me that their comfort with me and with talking about it would have increased. I also want to ensure a complete picture of what their current experiences are. So I'll ask about the frequency. How often do you think about suicide? You can also ask the how often question with perceived burdensomeness, thwarted belonging, and hopelessness. I ask about intensity. When you think about suicide, how intense are those thoughts? And I might give a scale of 1 to 10. How does this compare with how intense they usually are? That way I know if you're a person who chronically thinks about suicide, they may always be a 5. But if you aren't, then a 5 represents a more significant number for someone. Duration, how long have you had these thoughts? Have you made any plans or done anything to prepare for a suicide attempt? Have you attempted suicide in the past, and how recently? One of the assessment instruments that I like, because it kind of includes many of the main things that I often would ask about, is the Columbia Suicide Severity Rating Scale. It comes in screening versions and longer extended versions. There's pediatric and adult. It includes lifetime as well as more recent experiences. And there's versions of it for the emergency department, law enforcement, that family and friends can use. But as you can see on my screen, it asks, have you wished you were dead or wish you could go to sleep and not wake up? So that gets at suicide ideation as well as death ideation. Have you had any thoughts of killing yourself? For someone that says yes to that, there's a couple of follow-up questions. And then there's additional questions that ask, for example, about preparations for a suicide attempt. So how do you assess for perceived burdensomeness and thwarted belonging? There's a questionnaire called the Interpersonal Needs Questionnaire. There may be a better place to get it at this point. It's on Thomas Joiner's website, and that up to this point in my career, when anyone has asked me where do I get it, that still is where I tell people to go. I don't have a website where I attach it, but it also includes the scoring instructions for the items that are reverse scored. It has been translated as well, so it is available in languages beyond just English. And then how to assess acquired capability. So there is an acquired capability for suicide scale. If you just want to ask some questions in a less formal way, I typically ask questions about fearlessness about suicide, about how long they've had thoughts of suicide and how detailed any imagery they might have about suicide is, any plans or preparations that they've made related to a suicide attempt, previous experiences with self-harm and suicidal behavior, and exposure to violence. Another form that I really like for suicide risk assessment is from Dave Job's CAMS. And there's a form in his approach that's called the suicide status form. And it includes kind of an approach of pulling yourself up side by side in a collaborative way with a person while you're doing a suicide risk assessment, and begins with them completing questions regarding psychological pain, stress, agitation, hopelessness, self-hatred. And then they go on after that to consider what their reasons for living and reasons for dying are. And then you transition together to talking through some of the specific risk factors for suicide. And the form includes what those are in kind of a list way, but you can ask questions very similar to what I've given before as examples. A thing I really always liked about this CAMS suicide status form is that lots of people get really nervous once they start doing a suicide risk assessment. That certainly used to be true for me, not as true anymore. But I've done a lot of supervision of graduate students who get completely overwhelmed with anxiety when someone mentions thinking about suicide and tell me my mind went blank. I couldn't remember any of the things that you've taught me and that I know. And the thing I love about the suicide status form is you print the paper and you have the information that you need. And he's developed this with an empirical eye toward those risk factors that are have been associated with suicide deaths in research. So again, informal questions. Have you been thinking about suicide lately? How frequently have you had those thoughts? How long do they typically last? Do you have a plan for suicide? The thing that I always stress when I'm teaching about using this form is if someone mentions they have a plan for suicide, it's really important to ask them, if that wasn't available, do you have another plan? I want to know what they're thinking about so I can make sure that I'm being responsible with regard to a safety plan. So now I'm going to transition to management of suicide risk and start with some recommendations. So one of the places that folks often struggle is, where do I start? Do I start with treating suicide risk, or do I start with another problem? Let's say you have someone who comes in and most of what they're reporting is depression, but they do also report some thoughts of suicide. And what I typically recommend is for someone who is having more chronic suicide risk or the duration of it has been longer, then I typically recommend choosing a suicide specific treatment. Again, I strongly recommend Dave Job's CAMS approach. It has suicide specific assessment, like that suicide status form that I showed you before, treatment planning that is somewhat flexible to approaches. His intention is that it be pretty eclectic, that you don't just have to know CBT. Whatever approach you use, you can use it while you're implementing the CAMS risk management approach. There's ongoing tracking of suicide risk, and he has recommendations in it for clinical outcome. And basically, if the person reports very limited thoughts of suicide for X amount of time, 3 to 4 sessions typically, then at that point you transition out of the suicide specific treatment approach. If someone is reporting thoughts of suicide and it seems primarily driven by an anxiety disorder, depression, experiences like that, or outside of sort of the disorder arena, other life stressors, then you might consider an approach that more specifically targets those. For someone where it's marital counseling is needed, economic stressors, certainly reasonable to address those while kind of side by side with that, continuing to use something like the suicide status form to just check in with them on a weekly basis about thoughts of suicide in the context, of course, of a safety plan. In terms of between session care, it's important to think about what happens for our patients in between when we see them this week and when we see them next week. And so some of the things I think are really important to consider are reminding individuals about their signals of crisis, helping them to seek assistance with strong emotions that are tied to suicide risk. So that could be plans to contact you in between sessions if you are their provider, plans to reach out to family members, and then just more generally, reminders of how to utilize skills with regard to things like mindfulness. Also working with people around ideas for distractions. So do they have supports in their community? Are there particular activities that they can engage in? With COVID, one of the things that I saw a lot in my old neighborhood was people walking. I lived right on a park, and the number of people walking around that park increased dramatically during COVID. And it's something that isn't a significant safety risk, but it gets people out and moving, both of which are really positive and helpful. And even in communities with greater risk, I mean, of course, it depends how significant the risk is, but walks with other people 6 feet apart with masks on, things like that can still happen for contact with other people. I also encourage people to consider who they can go to for help and where to go for help. And then actions to make the environment safe. So if you have someone who has mentioned a firearm as the method of suicide that they would consider, then you want to talk through with them, how can we secure your firearm during this period that we deem your risk to be higher? Not that we're going to take it away from you, but that we want to limit your access to that firearm at a point that you may be in acute crisis. Crisis response plan is something that we often use to address those concerns. And on this slide, you can see what a typical safety plan looks like. So this is a template version of it. And it starts with asking folks about warning signs for suicide. So what are the things you think, the images that come to your mind, what kind of moods or situations may signal to you that you're developing, that a crisis is developing. The second step is internal coping strategies. So again, those can be things that you've taught or that they just know about themselves. When I do this, it helps me feel better. It could be going for a walk, giving someone a call, mindlessly looking at something on your phone, a game, Facebook, if it's not triggering, those kinds of activities. So we want people to write those down. And then the next step is people and social situations that provide distraction, naming who those people are or what those places are, and then specific contact information. Putting the phone number down, it's something I still always encourage people to do. Everybody has numbers in their phone, so it's not as critical anymore as it used to be when some of these forms were developed. People for whom you can go to for help. And again, having their contact information. And then in the next step after that, the professionals or agencies that you can contact during a crisis and whatever information that they need to be able to do that. That can include their clinician, urgent care services, suicide prevention lifeline is one example. And then the last section there, the step 6, is the making the environment safe. And there again, I'm really focused on how do we address any access to lethal means for suicide or other approaches that they've mentioned to you with regard to self-injury or suicide. So one of the places that this can get really tricky is in environments with few resources. And one of the things that COVID has actually been a great blessing in is the expansion of virtual mental health services. So while it used to be very few providers offered those, since COVID, most, I would say probably at this point, offer teleservices. And so the expanded ability to find a provider outside of your local area has like I said, expanded in a wonderful way. That allows contact with providers in larger areas. And I would also encourage those of you that are clinicians also to think about connections with other providers in larger areas for support, for resources as well. Establishing care networks that the person can step into during a crisis. And then just thinking outside the box. I often fall into a habit of, well, these are the things I do. And every once in a while, I just need to be reminded, well, there can be other ways I can do this. I can pull in other people that I might not otherwise think about. And so that's something that I just encourage you to do. And with that, although I'm a few minutes earlier than I intended to be, I am going to wrap up at this point. I thank you very much for your attention. My email address is provided here, as well as a very wonderful acknowledgement to the American Foundation for Suicide Prevention, both for inviting me to do this today, but also for being the primary funder of the research that I have presented today. And with that, I will transition to my last slide that has the QR code for the attendee evaluation form.
All right, we will open it up for question and answer in just a moment. But I do want to encourage you, if you're having troubles with the QR form, the direct link is in the chat. I do encourage you, the chapter is really hopeful that you will fill out this form. It's very important for our future planning. So please, we encourage you, please take the form, as well as a special treat for filling out the form. You will be put into a drawing to win a Hope shirt, which I sport all the time. They're very, very lovely, as well as a $20 gift card to Starbucks. I realize that some of you might be in communities that don't have a Starbucks. So if you don't have a Starbucks in your town, we'll trade it in for something a little bit different. So we'll take a few minutes to do that. And then we are going to start our Q&A session. You can either put your Q&As in the chat, which I will go through, or you can unmute and ask your question. The first question that we got in the chat box, is this work published somewhere that we can share with our rural mental health programs or colleagues? This research connection is being recorded. I will send it in an email with some information as well as the link again. But maybe that is a question for, is there more information published?
So there's a couple answers to that. One is I can, if it would be helpful, I can send a PDF to of the slides to Samantha, so that those can be posted. I can also send the publications, the manuscripts that have included the work that I've cited here. There's two primary publications that I've mostly talked about today. And I'd be happy to share those.
We have one question coming into the chat regarding CEs. Will there be objectives listed for CEs? As at this point, this particular research connection isn't open for CEs unless there is other information you can provide on that. And then we do have a comment. Our experience has been that as COVID hit, those in rural communities with no broadband who had been accessing mental health services had to withdraw from treatment for a prolonged window of time because of lack of access to needed technology. And then we had a comment, thank you for sharing. We have also began to train farmers and other community members in how to access suicide risk in conversations without specifically addressing the topic. Rural primary care docs have been trained in this too.
Yeah, the internet issues in rural communities are a tough one for me to say very much about in kind of recommendations. I'm glad to hear that it has improved. I know that that was an issue experienced in some of our communities as well. You know, people who have access to vehicles and can leave their area, you know, would go to the um, a larger area where there may have been a library or something like that that they can go to, but not everyone can do that. I'm not going to pretend that that's not a problem, because it is a huge problem. Um, and then, you know, more recently, even some of those public areas that people would go to, like a public library, have been closed in a lot of communities. Our community went into what they've called red status. Everybody's defining it differently. But we went into red status in September. And today is actually our first day out of red status. We finally had 7 days straight of less than 15% hospitalization. And so today, our libraries are reopening for people to go into the library. And so lots of services that have been closed to in-person interactions now are opening. But I mean, who can wait from September until February without having access, if that's something that is needed? And I'm not going to say that I think a library is a particularly comfortable place for folks to go for their mental health care. It's not very private. Did I accidentally screen share?
Someone is screen sharing. I'm going to see if I can turn that off.
To the other comment with regard to education of the agricultural community, that's really important. In our area, I'm employed now by our School for Veterinary Medicine. And I made that transition in part because of a strong feeling about getting mental health information into the hands of, in our case, veterinarians. But our school, we actually just finished interviewing for our inaugural class. The mission of our vet school is to serve rural and regional communities. And so my hope is that our veterinarians, being kind of in most communities, leaders in the community, knowing lots of people in these small towns, that as I am able to produce cohorts of students where we've included mental health education across the curriculum with them, I'm available to those students for mental health and other services, that we will increase the number of people who have some of that information. And I'll be teaching them about how you identify it. In our community, there's also been some efforts at educating other folks in the rural communities, those in agriculture, business owners, for example, that sell farm equipment, about some of the things to look for. And there's also been a focus on sharing some of this information with some of our ag lenders, who may be the first point of contact for someone that is experiencing significant financial difficulty as a function of COVID and lots of other things at this point. I'm looking at the questions. Let's see, where do I think we left off? There's the education requirement. Are you also working with other groups, UT Dallas Center for Brain Health, to also evaluate what is going on in the brain when you warning signs appear? I am not at this point in my career. I am transitioning into much more of a clinician role and less of a research role. There are lots of other very competent suicide researchers that neuroscience is their area of interest. It has not been one of mine, so that hasn't been an area that I have focused on. We have done some work with neuropsychological assessment as part of our assessments, but in terms of things like brain scans and that kind of thing, I have not been involved in that. Am I planning to continue research in this area? Yes, as I acknowledged before, in a more limited way. So I will probably continue some of the same kinds of work that I've talked about before. I mentioned that the results that I presented were somewhat preliminary. We're still kind of digging into the data to identify some of some of those relationships. And so my hope will be going forward that although I won't spend as much of my time doing research, that we'll kind of dig deeper into some of those things that we've seen. And I'm more likely to have veterinary students and veterinarians just as a function of my school affiliation, but from those rural communities involved in some of the work that I do going forward. What has been the response from faith communities and in rural communities? It's been positive. One of the things I learned early on is in rural communities, it takes time to establish relationships, and it takes time to establish trust. And in the communities that we've done much of this work with, I've been fortunate in that there was a larger infrastructure that my study built upon. There's a large neuropsychological study that looked at brain changes related to aging and how that's associated with Alzheimer's in these rural communities. And then my study added to that as there started to be a lot of concern within the communities. The communities actually approached us initially to say, hey, we're having problems with depression and suicide in our communities. Would you be interested in kind of partnering with us? And so that's how I actually initially got started with this. So for me, it's been important to work with the community in a larger way as it pertains to suicide risk. And I haven't wanted to be someone that just comes in, does my work, and then kind of see you later. During the time that we had data collection going for, probably 5 years, every few months we would have a meeting within the community with an advisory board in the community that had lots of representatives from each of the communities, and kind of talk about, this is how it's going, this is what we've seen so far, in an effort to make sure that what we were doing was also going to be giving back to those communities. Okay, COVID has hit many residents in nursing homes hard. I've noticed it firsthand. Do you see these questionnaires being implemented in nursing homes, especially in rural areas? I would absolutely love it. Do I know if it's happening? I don't know if it's happening. It's such a tough time with the increased medical needs. And so the limitations in who can come in makes it difficult to offer anything to folks that would tax their system. But at the same time, absolutely, if we were asking these questions more regularly in nursing homes, assisted living, retirement communities, I think it would be very, very beneficial. So if you know people, certainly recommend it. In Lubbock, which I would say is more regional, less rural, I've worked with some residents actually at one of the facilities here that it has independent living, nursing care, and assisted living. And this couple, I know them because we bought our last house from them, and then became friends with them and stayed in touch with them for a long time. They happen to be much older than us. But we've been in touch with them and talked with them about kind of, how can we provide information to you that you can share with other people. And so, we've had something more informal there.
We might have already answered this question. Is there an educational requirement for the assessments, or only done by a doctor, nurse, or social worker?
There is not. Certainly there's some psychological tests that have with them an expectation of certain level of education, but I don't think that is necessary for basic surveys like the interpersonal needs questionnaire. The Columbia was developed to be administered by anybody, including family and friends. And then I think that it certainly requires reading a little bit about it to learn about CAMS and kind of what to do with the information. But even Dave Job's CAMS book I think it would be something that you could pick that up and pretty readily learn how to use the suicide status form without much specialized mental health education. Where I think it gets difficult is if you don't have as much mental health education, what do you do with the information? And that's a place where I think it gets a little bit more difficult. You ask the questions, you find out someone's thinking about suicide, they have a plan for suicide. You need to then responsibly use that information for creating a care plan. I still think that's something that people can do. You know what some of the resources are in your community. Even things like hooking people up with friends and supports, that it's invaluable. So yeah, I don't think that with regard to suicide prevention, I don't think we want to get into a way of thinking that you need a PhD in clinical psychology or in school psychology or whatever else, to be involved in it. That's just not, it's not realistic, and I don't think it's necessary, and it limits who's doing the work. And I think I worry a lot about then people thinking, well, I'm not qualified to do it, so I'm just not going to ask. And if you don't ask, then you don't know and you can't do anything about it.
Great question. And of course, I would like to just add in more information about AFSP. We do tons of prevention education trainings on all different levels about warning signs, risk factors, and how to have strong conversations. So if you're interested in learning more about some of these programs or these trainings, reach out to us, afsp.org/North Dakota. But that was a great question. Keep the great questions coming. This also may be a repeat question, so please disregard, but are you also working with other groups to evaluate what is going on in the brain where these warning signs appear? An example was the Dallas Central for Brain Health.
Yeah, that was one I read and answered that it's not an area of emphasis for me in terms of things like brain scans.
Hi,
Hi, Rebecca.
can you hear me okay?
Yes.
Okay, awesome. I just wanted to add to the conversation that Maddie brought up about implementing questionnaires in the nursing home. And I just wanted to share, I'm a student at the University of North Dakota at the occupational therapy program. And we had a project, an advocacy project, and we reached out to various different programs. And our specific project was reaching out to the Department of Health in Wyoming, because that's where we live, and advocating for mental health screenings, the PHQ-9, to be implemented in conjunction with COVID-19 screens. And they ended up writing us back and implementing some of what our research suggested and what we were suggesting. So I would just say to Maddie that now Wyoming is a little different because we're so small and it's easier to kind of get replies from people. But I would just really encourage, anyone to get out there and advocate and write letters to whoever is in charge or whoever would be that person to implement those questionnaires, because sometimes that's all it takes is just an email or a letter.
That's awesome. Thank you for sharing that. That's fantastic to hear. A sort of side story to that, when I first started doing work in my first few studies were with the primary care clinics in our health sciences center, and all of those studies were with older adults, and I was amazed at how low the scores were for assessments of depressive symptoms among the participants in our studies. And I went back to the gerontologists that I'd worked with in the clinics to recruit. And what I found was that they had a system very similar to that. Everybody in the clinic filled out a PHQ-9, and the rates of medication prescription for antidepressants were so much more, they were just assertive in identifying and treating depression. And so it was one of those things, like, so glad this is happening from a patient perspective. So hard on my research, though, because now there's no variability in some of the outcomes that I'm trying to do research on. So, I mean, kudos to them, but they were doing something similar to that. It was something I'd kind of wished I'd known from the beginning. I would have partnered with a different clinic. But it was great to work with a clinic that already had in place procedures like that. It wasn't a nursing facility, though. I think that's just fantastic.
Another question, do you think ageism plays a role in how providers approach suicide in older adults? For instance, not believing an older adult is capable of taking their own life by their own hand, or not serious?
I do think that is a problem. I think that both sides of that are accurate. One, not taking seriously the possibility that someone could carry out a suicide. The other thing that worries me as well, and you didn't say it quite like this, but the belief that, well, that person's older, they don't have much life left, in a way that I think really devalues the lives of older people. Or another thing I see more often is people having the belief that depression in late life is a normal experience. And I mean, certainly across the lifespan, depressive symptoms occasionally are a very normative experience. But to discount someone's depressive symptoms because they're older, and you think all older people are more likely to be depressed, is incredibly wrong. It's not accurate at all. And it discounts the suffering that people are experiencing. Okay, so the comment is, since it can be challenging to reach some adult farmers and ranchers and rural citizens due to the lack of internet access, have you worked with schools to provide information that can be sent home to share with adult relatives? I have not yet, but that is a fabulous idea. We have mostly focused on reaching the adults, but you were right that it can be very difficult to reach the adults. We're in some of these places I mentioned before, the like the farm equipment store, that tends to be a place where people congregate. And so, providing information in locations like that and working with the owners of those businesses can be helpful with getting the adults. But absolutely, we hope that whatever comes home with children is read by adults. And so sending home some of this information with kids can be great if it's something that the schools are comfortable with. It wouldn't shock me for some schools to say, gosh, I don't want to send that home in a kid's book bag. That's not a good idea. But I think it's something that could be done, through a sealed envelope, for example.
We have a few more minutes for just a few more questions. So if you have more questions, please put them into the chat, or you can unmute if you're not shy. Just some few reminders. Again, please take the evaluation survey. It helps us very much. As well, there is a prize for someone who enters the drawing. We have a lot of great things happening in our chapter coming up. So please check out our website, afsp.org/North Dakota. We have North Dakota State Capitol Day happening in a few weeks. It will be virtual this year, but it is a program or an event that helps us connect with our legislative leaders. There's also a professionals workshop happening at the end of the month, attachment-based family therapy workshop. CEUs are given for social workers and counselors, so definitely check that out. As well as our local North Dakota chapter does all kinds of different things across the state: prevention, education, advocacy, and of course, as Mary pointed out in the chat, we do have a lot of resources for suicide loss survivors. So that is some information on our chapter. We just have a few more minutes. If you have any questions, please either unmute or put them into the chat box.
If you don't, I thank you all for being a wonderful audience today. It's lovely to get to present this work that we've spent years doing, and to share some of my enthusiasm and passion about being involved in helping with suicide prevention in rural communities. I'm one of not many that has really devoted a good bit of my professional energy to suicide in rural communities. It was quite surprising to me when I first started doing work in the area and trying to figure out, well, what has everybody else done? Lots of areas of suicide prevention, you can figure out what has been done before you in terms of things like risk assessment, but it was really limited. I talked to a couple of people who did work in rural communities on things like depression, but even their protocols for managing suicide often consisted of things like, well, if someone is telling us that they're thinking about suicide, well, then we don't include them in our further data collection. Well, that's not helpful at all. So we've done a lot in kind of trying to figure out how to do it in a way that is, as to my view, safe and acceptable to people. And you're welcome to those saying thank you. It's my pleasure.
I believe that is the end of the questions, but on behalf of AFSP, we are so thankful for you for presenting your research and for sharing your knowledge with us today. Thank you for leading this research connection, and thank you to all of our attendees who attended our first virtual research connection. So that concludes our research connection for today.
Thank you so much.